All right, welcome back. Today we're doing something a little different. We're going to step right into one of the most intense situations any surgeon faces, the oral board exam, or what many call the viva. We're going to simulate a full clinical station on breast cancer, breaking down every critical decision point you need to know to prove you're a safe and competent consultant.
Good morning, candidate. Please have a seat. We'll be discussing a case in breast oncology. Your station begins now.
I'd like you to manage a patient for me. So, here's the situation. A 52-year-old woman who is otherwise perfectly healthy comes to you with a painless lump she found herself. Her mammogram and ultrasound look suspicious, and you've got a core biopsy back. It confirms a 2.5 centimeter T2 clinically node-negative invasive ductal carcinoma. It's ER positive, PR positive, and HER2 negative. So tell me, how do you manage the breast?
Thank you. Well, the first thing to say is that my management would be guided by our multidisciplinary team. For the breast itself, there are really two primary surgical options, and it's crucial to know they have equivalent survival outcomes. The first is breast-conserving surgery, a lumpectomy, followed by radiotherapy. The second is a mastectomy. Now, the choice between these really comes down to a few things: the tumor size and location, what kind of cosmetic outcome we can expect, and of course the patient's own preference after we've had a detailed chat about the pros and cons of each.
And the axilla?
Right. Since the patient is clinically node-negative, based on our exam and her imaging, the absolute standard of care is to stage the axilla with a sentinel lymph node biopsy. We do this at the same time as the breast surgery. What we do next for the axilla completely depends on what that biopsy shows.
Very well. So you proceed with the lumpectomy and the sentinel node biopsy. Let's say the intraoperative frozen section comes back and it shows that 2 out of the 3 nodes you took are positive for cancer. No extracapsular extension. And your final pathology report says the lumpectomy margins are clear. Now what? What are your options for the axilla?
Okay, so this is a classic scenario where our practice has totally changed. In the past, a positive sentinel node automatically meant a full completion axillary dissection. But now, thanks to 2 huge trials, Z0011 and Amaros, that's not always the case. For this patient, since she's had breast-conserving surgery and she's going to get whole breast radiation, she perfectly fits the criteria for the Z0011 trial. This trial showed us that if there are only 1 or 2 positive nodes, we can safely just stop and not do any more axillary surgery. The thinking is that the radiation to the whole breast actually treats the lower part of the axilla too. The other option comes from the Amaros trial, which found that giving targeted radiation to the axilla is just as good as doing a full dissection for controlling the disease, but with way less risk of lymphedema. So my next step would be to discuss these 2 fantastic, evidence-based options with her.
Let's move on. I have a new scenario for you.
Okay, a new patient walks in. This time she has a large 6-centimeter tumor that feels fixed to her chest wall. You can see skin changes over it, and you can feel matted lymph nodes in her axilla. This is a clinical T4B N2 cancer. How does your initial approach change for this kind of locally advanced disease?
Right. This is a completely different ballgame, and it requires a total shift in our strategy. The key here is that surgery is not the first step. Not at all. First, we have to do a full metastatic workup, a CT of the chest, abdomen, and pelvis, plus a bone scan to make sure the cancer hasn't spread. Second, this patient must be discussed in our multidisciplinary team meeting. And third, the absolute cornerstone of her treatment is neoadjuvant chemotherapy. We give the chemo before any surgery to try and shrink the tumor. Only after we see how she responds to the chemo do we even begin to think about surgical resection.
And just to be clear, giving chemotherapy first is the standard for several specific situations. This includes large T3 tumors, especially if we're hoping to do breast conservation, and all T4 tumors, like the one you just described. We also do it for advanced nodal disease, so N2 or N3, and for the more aggressive biological subtypes, like HER2 positive or triple negative cancers. And for inflammatory breast cancer, it's the only way to go.
Good. Let's move to some special populations. I'm looking for quick, precise answers here.
Okay, a 34-year-old patient is diagnosed with breast cancer at 20 weeks gestation, so she's in her 2nd trimester. What are the key principles of managing her, and what is absolutely contraindicated?
Managing breast cancer during pregnancy is incredibly complex and requires a dedicated team: oncologist, surgeon, OB, maternal fetal medicine, the whole group. For staging, we'd use a chest X-ray with an abdominal shield and an abdominal ultrasound to avoid radiation from CT scans. The absolute no-goes during pregnancy are radiotherapy, the blue dye we sometimes use for sentinel node biopsies, though the radioactive tracer is okay, and anti-HER2 therapy.
The good news is that chemotherapy is generally safe after the first trimester, and surgery, usually a mastectomy to avoid needing radiation later, can be done safely in the second trimester.
Okay, and what about a male patient with a positive sentinel lymph node biopsy?
That's a fantastic question, and it's a critical distinction, a classic exam pitfall. While a lot of the principles are the same for men and women, men were not included in the Z0011 or Amaros trials. Because of that, we can't apply those findings to them. So, for a male patient, a positive sentinel lymph node biopsy means he needs a completion axillary lymph node dissection, period. There's no role for omitting surgery or using radiation instead in this case.
Last question, candidate. This one is all about patient safety.
Yes, of course. There are several absolute contraindications to breast-conserving surgery, situations where a mastectomy is really the only safe option. These include any patient who can't or won't get radiotherapy, like a woman in her first or second trimester of pregnancy. Others are inflammatory breast cancer, diffuse suspicious microcalcifications that we just can't clear with a good cosmetic result, and multicentric disease, meaning tumors in different quadrants. And finally, if we've tried to re-excise margins and they are still persistently positive, we'd have to proceed with a mastectomy.
Excellent. To finish up, please summarize for me the 5 most important takeaway points from our discussion.
Certainly. I think the whole discussion really boils down to 5 essential points for safe and effective breast cancer management.
First, any management plan has to separately address both the breast and the axilla. You can't forget one. Second, if you have a positive sentinel node, you absolutely must know the specific criteria for Z0011 and Amaros to avoid unnecessary dissections. Third, locally advanced disease is a medical issue first, not a surgical one. It gets neoadjuvant therapy before any operation. Fourth, always remember the critical exceptions for special groups like pregnant and male patients. And fifth, for patient safety, you have to have the absolute contraindications to breast-conserving surgery memorized.
That kind of structured approach demonstrates safe and competent practice. You have answered well.
And just like that, we've successfully navigated a pretty complex consultant-level exam station. You can see how breaking down each problem into its core parts, the breast, the axa, and the bigger systemic picture, and then applying the evidence from these key trials allows you to build a framework for safe care. And that's something that goes way beyond just passing an exam. Thanks for joining us.